Welcome back to Zoom, people, too. We have a new person helping with Zoom. Is this on? You can hear me? Anna Rose, I'm going to ask Zoom people, if there are any problems with audio, would you please send the name of the problem through the chat. Looks like we're doing okay with audio and video on Zoom. I hope so. Welcome back. Hope you enjoyed lunch. If anybody just arrived and wants the continuing education credits, please just be sure to sign in. So there's a little sign-in sheet outside. I was told to say that. Okay, Jen will do the introduction, please. This is my colleague, Jen DeSoy.
Good afternoon. I'm Dr. Jen DeSoy. I'm the new founding chair of the Department of Occupational Therapy here at King's College. And I'm really excited to be having our next speaker. This conference has a lot of meaning to me and as our profession as a whole. In the over 150 plus standards of OT practice needed for accreditation for the curriculums across the country, health disparity, health inequity, and/or social justice is only mentioned once. And though this is a major tenet of our profession and mission and vision, I really believe that the future of healthcare really must have a significant focus on competency in social justice, health disparities, and community health and wellness. And as an educator, a future generation of OTs, it is my responsibility to build competency, awareness, and advocacy in social justice. While creating the OT program here at King's, social justice is one of the curricular themes, and the students will also have the ability to specialize in social justice, one of only few across the country, and as a future healthcare practitioner. So I'm really thrilled to be able to introduce our next speaker. We are really pleased to have Dr. Anita Sreedhar, who is an internal medicine resident at the Department of Primary Care and Social Medicine at Montefiore Medical Center in the Bronx, New York. She completed her medical degree at Rutgers Robert Wood Johnson Medical School and also holds a master's degree in public health from Columbia University, as well as an undergraduate degree in English and theater studies from the University of Pennsylvania. Prior to her medical school, she was a journalist and one of the co-founders of the Zomi Center of the Study of Non-State Spaces, which assists the public health initiatives in conflict zones. She has reported from Afghanistan and India, and she currently serves as a member of Zomia's board of directors. Her research interests include the social and structural determinants of health. Her clinical experiences includes ongoing service for the recently arrived immigrants in the South of Bronx, for patients recently released from prison or jail systems, and for the survivors of torture and trauma. We are really grateful to have Dr. Sreedhar here to present to us today the body politics and personal and public health. Dr. Sreedhar, thank you.
Thank you so much for that wonderful introduction, and thank you so much for letting me be here today. I'm very excited to talk to you all. So I'm going to be talking about vaccine hesitancy, and a lot of what we talk about in terms of vaccine hesitancy, this is a perspective really from the Bronx, where I practice and I'm completing my residency training. These are going to be some of the objectives that I'm hoping to hit. And I'd like to start off by maybe talking a little bit about where in the Bronx I practice. So I like to use the MTA New York City subway map because it's so convenient. It's a great way to point out, the big spots in New York City. So we're going to follow the green train line. So this is the 4 train in particular. And I practice all the way at the end at a hospital, all the way at the end of the 4 train line. And the Bronx is north of Manhattan. It's only about 22 minutes per car without traffic, and about 45 minutes on the express train. But something that I hope that you'll come to appreciate through this talk is, even though it's only 7 to 10 miles north of Manhattan, the Bronx is a really different place. It's very, very different from the rest of New York City. Much of this talk is going to be rooted in the year 2020 to 2021, so really around the first wave of the pandemic. I know that a lot has changed since then, and just vaccine hesitancy, of course, now we're getting to a point where at least 80% of all Americans have at least 1 dose of the vaccine. And this is, this is a context of where we have to remember this is against the context of like mistrust, really, of the vaccine. They do not prevent illness, they reduce its severity, but we also required vaccine mandates to help make this a reality for us here. And still, 2/3 of all Americans have not received full immunization, despite the vaccine being readily available. And so that's to the fact that we still have a ways to go in terms of addressing mistrust, but also addressing vaccine hesitancy. A summary of what I talk about can be found on the New York Times. This piece came out in December of 2021. And this was right after a block I'd completed in our medical ICU unit. So fall of 2021. And I remember on one of the nights, just walking down the hallway, looking at each of the rooms. And more than half of those patients were on ventilators. We were still seeing COVID-19 pneumonia cases that required hospital level care or ICU level care. All of those patients on ventilators had a diagnosis of COVID-19 pneumonia. All of them were unvaccinated, and all of them were from the Bronx. And what you have to understand is that that's not just true of patients. A week prior to that, a neighboring healthcare system had actually been in the news because 1,400 of their nurses had refused to get vaccinated and so no longer had their job. And 10% of that 1,400 weren't just nurses that were providing day-to-day care. These were people in leadership positions. So we're talking about nursing managers. And so, what I'm sharing is basically that the Bronx in general, we've lagged behind in the metrics for vaccination rates. We are the last to get vaccinated. We are the most likely to be hesitant about getting the vaccine. And every week during the pandemic, you'd see these numbers kind of come out. What's important to remember is that this is happening against a backdrop where all of us in the Bronx had a front row seat to the worst of the pandemic. In addition to metrics that we're talking about, lack of vaccine uptake, before that, all of the metrics that were coming out were pointing to the fact that we in the Bronx, unlike the rest of New York City, we had the highest rate of COVID-19 infections. We had the highest rate of hospitalizations and the highest death rate overall. And this wasn't just true of our patient population that we were seeing in the hospital. This was true for communities that were living in housing complexes around the Bronx. It wasn't uncommon to walk around and to walk into lobbies of these housing systems and to see makeshift memorials literally go up overnight for memories and to commemorate those that were lost. And so this raises a really, it raises a really interesting question. How is it possible that the place that has the front row seat to the worst of the pandemic, how is it possible that we are also the least likely to be vaccinated? How does that come about? And that's what I'm hoping to address today or talk about today. A lot of folks, of course, had very similar questions to this. And when I first started looking at vaccine hesitancy and sort of trying to figure out what do folks kind of think is happening, there's really three kind of big buckets that a lot of theories fall into. The first has to do with accessibility. So this idea that communities that are less fortunate, or communities, working class communities, generally don't have the same access to healthcare as other communities do. And so these are folks who are less likely to show up at your doctor's office, less likely to access preventative care, less likely to therefore get the vaccine. Second big bucket has to do with racism and race. This idea that in the Bronx, we are home to a very large community of color. And we're talking about brown folks who have a general distrust of the medical system, the legacy of infamous things and infamous trials like the Tuskegee syphilis trials hang over all of us. And so communities that are less likely to trust their doctors, trust the medical system, and show up to get the vaccine. And then the last theory falls into this bucket of political affiliation. So this was, over the summer, you'd hear a lot about the fact that if you voted Republican, you were less likely to have been vaccinated or want to have the vaccine versus if you had voted Democrat. So taking each of those sort of buckets apart, starting with starting with accessibility, I want to make it clear that when I say vaccine hesitancy, what I'm talking about is either you're not getting vaccinated or you are delaying getting the vaccine despite it being available. In the Bronx, certainly in New York City, because of both the funding as well as the approach from the Department of Health in the city of New York, the lack of accessibility really isn't a reason why we weren't seeing vaccine uptake in the Bronx. Obviously, I know that that's probably different for other parts of the country, but certainly in New York City, that was not one of the reasons. When we come to the second big reason, and we talk about race and racism, this is a slide showing some data from the Kaiser Family Foundation. And if you look at the slide, based on race, if you identify as African American, you are far more likely to wait to get the vaccine, and you're far less likely to be vaccinated than if you identified as white. However, when they looked at the data a little more closely and broke it down, what they showed was if the moment you control for college education, the difference between Black and white vaccine attitudes disappears. There's a lot of really strong sociology data or sociological research that actually shows that college education is also an excellent proxy for class in an American context. And so what this kind of suggested is that, it's class versus racial background that was kind of explaining part of those differences in vaccine attitudes. I want to be very clear here and just pause to say this. I am not suggesting for a second that, racism and its healthcare effects on Black and Brown communities doesn't exist. I mean, it absolutely does. As Dr. Hoskins very eloquently pointed out, African American women suffer from far higher rates of both complications as well as mortality when they're giving birth. They're more likely to get C-sections. They are also, in the context of getting C-sections, less likely to get adequate doses of anesthesia and pain medications necessary. And so, when we're talking about Black and Brown folks and working class folks going through the medical system, they're not having the same experiences as their white counterparts. They're not experiencing the same healthcare outcomes. But when we're looking specifically at what might be shaping the choice to get vaccinated or not, that answer to me is not as simple as just Black or white. And so coming to the last bucket, political affiliation. So if we add partnership to this picture, this is also from the Kaiser Family Foundation data. It's the KFF COVID-19 monitor website. And it showed in surveys that if you voted Republican, you were far less likely to get the vaccine or been vaccinated. Again, however, when you break down the data, what they showed was that if you were an unvaccinated Republican, then you were more likely to not have a college education. And so you were more likely to be working class. This is another study that was actually done by an organization in Michigan. They actually mapped vaccination rates by area, education, and political affiliation, and they also found a very similar pattern emerge, which is that political affiliation didn't quite match the vaccination rates or vaccination attitudes as much as whether you had a college education or not. So, for example, in Detroit, where Biden won over 90% of the vote, less than half the residents reported having been vaccinated. So when we think about political affiliation, it's true that Republicans are less likely than Democrats to get vaccinated, but this difference lessens when you control for class. And so political affiliation matters, but so does class, but they both point to the same underlying phenomenon. And so the question is, what is that underlying phenomenon? And why is there such a class difference in terms of vaccine attitudes? To help answer that, I need to start telling you a little bit about the Bronx. So I practice at a clinic that is walking distance from Yankee Stadium. It sits in the 16th New York Congressional District. And by the 2010 census, 40% or so of the population lives at or below the federal poverty line. What that means in practice for me at my clinic, the vast majority of my patients live either in public housing or low-income housing. The vast majority work in the service sector. So they commute to Manhattan to work in jobs that have to do with food prep, baristas at Starbucks, housekeeping, and none of them really were able to take time off during the pandemic. They all worked to continue putting food on the table. And when we talk about public infrastructure in the Bronx, talking about crumbling infrastructure that kind of year after year is feeling the effects of the burden of having to, withstand the onslaught. And so folks, even during the pandemic, had to reach out for charity care, not just for masks or for meals, but even for cleaning solutions or things to help keep the building together and keep the building running or the lights on, for example. So when we first started doing these interviews to kind of get a sense of, what is it that you're thinking about when you decide to get the vaccine or not? One of the things that really came across was this very acute sense of people saying, we feel abandoned. Nobody really cares about us. There's this beautiful quote. This was something the women I was interviewing said to me. And she said, we are the last on the battlefield. Nobody notices us. And this was a sense that came through these interviews again and again and again, which was that people were unlikely to trust institutions they felt had not helped them or had done enough to help them. And to show up in the middle of a pandemic all of a sudden and suddenly say, hey, by the way, why aren't you getting the vaccine? I don't know that that messaging really came across in a way that we had imagined for it to come across. And so there was another great quote. What happened was that the city at some point actually started a citywide program, an incentive for folks to get vaccinated, and they were offering $500 to municipal workers. So you came in, you got the vaccine, and you get cash. And she said to me, you don't give us money for anything. And now all of a sudden you want to give us $500 to get vaccinated. What's your angle? What are you after, right? Be clear, these aren't attitudes that happened because we had the COVID pandemic that have occurred over years and decades to reach this point, right? In New York City, certainly, I can speak to the fact that we see this messaging again and again and again, where folks are told either directly or indirectly that they're basically on, you are responsible for your own health. You're responsible for what you put into your body. So you're responsible for you. And it's not, you can't expect the government institutions to come about and fix those things for you. That happens because this is coming on the heels of, deregulating industries and privatizing a number of services. The Bronx has a really rich history of this. So one of the legacies that folks talk about again and again, during the 1970s, we had the Bronx fires, where entire buildings burned completely to the ground. And this was in the setting of services to fire departments within the city, but especially within the Bronx. On top of that, people always talk about the fact that when families lost the help that they needed to get back on their feet, to be able to find new homes. And these are things that are very acutely on the minds of people when they're coming in and interacting with institutions like the Montefiore Medical Center. And all of that idea of deregulation, deregulating industries, privatizing services, all of it kind of falls under this term neoliberalism, right? Right now for NYCHA, which is the New York City public housing system, and there's a to sell 50% of the stake to private developers in New York City. And this was very much, again, on the minds of folks when you went in to talk about, why aren't you getting the vaccine, or what are you thinking about? And to sort of ask that question, I mean, you feel kind of silly, right? Because they're sitting there talking about the fact that they may lose housing, money going into supporting public infrastructure, that they're having to go to work under these circumstances where they're noting that like other people get to distance and not have to show up. And it kind of sets up this dynamic where there's a big divide between what we're asking and what we're focusing on and what they're focusing on. One of the gentlemen who we interviewed, he drives an Amazon truck for a living. And we said, what is it other neighborhoods outside of the Bronx? And he said, when you're in a high tax bracket, the government protects you. So why wouldn't you trust a government that protects you? Of course, you're going to get vaccinated. And he said, but that's not true for the Bronx. That's not what's happening here. And the more he started to talk to us, the more you got the sense of not only is there an acute sense of being abandoned, but there's a calculus that folks in these neighborhoods are having to deal with and make every day. There's a risk profile, right? That includes things like crime, unstable housing, tenuous jobs, addiction, lack of access to resources. And so every single day, folks are waking up and having to make decisions to overcome risks that have to do with their day-to-day living. When you add COVID to that, it's just one of many risks that they're having to face in their life. That's very different from when you come down to Manhattan, where COVID is probably one of the biggest threats that you're facing. So the risk calculus and the risk kind of profile changes, and the decision making to get the vaccine also changes. But also, again, people do not trust institutions that do little for them. So one of the things that folks always say to me at this point, in the talk, always, yeah, but there's other things really happening here, right? There's other factors. For example, we're in an environment where the right wing in particular is spewing a lot of internet conspiracy theories, and there's QAnon and alternative facts. So it's hard to shake the sense that maybe there's something else happening here as well. But if you actually look at the history of vaccines, a lot of what we see today about vaccine hesitancy goes right back to when vaccines first came about, right? So vaccine hesitancy is actually as old as vaccines itself. And this goes back even to the time of when, Edward Jenner was developing the smallpox vaccine. At the time in the UK, there were various sections of society. Mid-19th century, you had working class movements that were opposed to vaccination programs that were being unrolled. And thinking about, if we think about coming here to this country, there's a lot of vaccine hesitancy that happened in working class communities here historically as well. This is an excerpt from a book, again, in the Bronx. This was during an attempt to have a smallpox vaccination campaign. And I'm just going to read a little bit of it. So after a case was discovered in the area and the news spread that everyone would have to submit to a doctor's lance, people, quote unquote, fled from houses and sought to elude the vaccinators. The Daily Tribune reported, many of the men and women attempted to escape, going down fire escapes and climbing onto the roofs, but policemen were at hand at every place of egress, and appeals and entreaties were unheeded. And they were, in addition to this idea where they're trying to escape getting the vaccine altogether, there were also protest marches, and there was a lot of sort of hullabaloo against this idea that they're supposed to get vaccinated. That excerpt that I just read to you comes from a book called The State of Immunity. It's by a historian, James Colgrove. Something that's interesting that Colgrove highlights is that vaccine hesitancy actually extended across class backgrounds in the mid-19th century. And so there were these anti-vaccination societies that popped up among the upper and upper middle class folks. This one on the left, if you take a look at it, was a pamphlet produced by one of those societies. And you can, I don't know if you can read it, but it says, vaccination is a curse and a personal menace to personal liberty, which I think if you think about can also, oh, sorry, sorry about that. Which if you could, if you think about could also very much apply to the ways that we talk about the COVID vaccine today. And so anti-vaccine attitudes have been around for a while. This question of who gets to trust the institutions that provide them and who gets to trust the institutions that encourage them, that's the part that's changed. Just want to show this one other slide again. This is one of my favorites. So the Quest was an anti-vax magazine from the 1920s, and they actually had an anti-vaccine hymn, that's the music sheet on the other end. I don't read music, but I'm hopeful somebody somewhere someday will read this and actually record it and send it to me. And it's super interesting, right? Because it's like, what is it about vaccines that spawns this kind of response? I mean, it's you don't really see this with a lot of other interventions. And you don't see that with a lot of other medical procedures, really. And I think that's because, when you think about vaccines, they're kind of unique. And that's because they not only are designed to protect the individual from disease, at the same time, they're meant to protect the community. And so whenever you talk about getting vaccinated or you talk about a vaccine, you're talking about two different values that are actually in tension with each other. This idea of individual liberty versus communal obligation. And so I think when you're tracing history of vaccine hesitancy in vaccines, what you're also tracking is a society or a community's response or weighing each of those values against each other. And that's important to kind of understand when, we see periods of time when vaccine hesitancy kind of disappears. And so, we're going from the mid-19th century and the 1920s when they're singing hymns about being anti-vaxxer to the 1950s, where all of it almost mostly disappears. The 50s was when we had the polio campaign. So these are pictures of folks lining up to get the polio vaccine. At the time, it was considered to be a pretty miraculous scientific development. The vaccine had been created, and there was almost no organized vaccine hesitancy movement. There's a really beautiful book by David Oshinsky. It's called Polio: An American Story. I highly recommend. And Oshinsky really points to the fact that the problem in the 1950s during these vaccine campaigns was actually the opposite, which is that you saw working class communities of color having to raise their voices to say, hey, what about us? You can't forget us. We want the vaccine as well. And the interest, in addition to that, the other interesting part is there was actually a number of high profile cases that complicated this. So there's an incident where during production of the vaccines, something went wrong, something got tainted. And so a number of children actually got polio when they got the vaccine. And despite that, you still didn't see the degree of vaccine hesitancy that you saw before or after this. This takes us into the 1960s, where we have campaigns against measles, mumps, and rubella. Again, these are society-wide campaigns. They had a lot of support from communities. There was some hesitancy, but most of it seems to have been in much smaller religious communities. But other than that, nothing, again, at the level that we were talking about before. And so states actually began instituting mandates where you have to get the MMR vaccine before you can start school. And this continued until 1981, when every state basically had this in place. And again, really not really any records of like major pushback against this. So it's a pretty striking change, right? Because you're looking at that 50-year period and you're going from like the 1880s to 1920s, 1930s, when vaccine hesitancy is central to vaccination campaigns and vaccines. And then you kind of get to the 1950s and the 1960s and it kind of disappears. And so this is kind of the next question, which is, why is that? Where does that come from and how does that happen? And I think that, biggest change that you see when you look at this post-war period is that it was a period of massive social programs and massive government intervention in all aspects of life. In the 1960s, you have Medicare and Medicaid that come about. You also have Johnson's War on Poverty, which was one of the most ambitious set of government programs that tried to address the root of inequality and poverty. You had this ethic in the country that social intervention wasn't such a bad thing. And you didn't really see partisanship over that idea. I mean, it was widely accepted even on the right. You had programs like Head Start, which was supporting and encouraging children from low-income backgrounds to be able to get into preschool. And what was interesting about that the very people running that program were also trained to give vaccines. And so what you're seeing is, this idea that vaccinations are linked to other social aspects rather than seeing them as just this sort of isolated, siloed medical intervention. It's tied to this idea of overall well-being. You also had community health councils around this time. So these were programs where local communities were given a very large a share of decision-making power over the trajectory of healthcare programs that were introduced into communities. So there would be a board that were drawn from members of the community. Sitting at the same table would be folks from local hospitals or the local Department of Health. And these community boards are really pretty incredible in the sense that the community and the folks that were sitting at the table, this wasn't just a question of lip service and performance. We're talking about people who had equal seating at the table and were able to challenge the trajectory and the narratives that were put forth by hospitals, by public health workers. And that's important because, again, you have to remember the risk profile and the calculus and what folks are thinking about in their communities can often be very different from the priorities that folks from the hospital system or the Department of Public Health are bringing into those areas. And so, only in the early 1880s, you sort of now see the modern anti-vax movement start up again, really in 1981. And I think the reason for that is that, in the post-war period, this idea and commitment to universal social programs aren't targeted just to individuals, but targeted to everyone, simply by virtue of belonging to a political community. And what that did, I think, was it not only inculcated a sense of communal belonging, but it also inculcated a sense of social solidarity. Simply by virtue of belonging to the same community, you are owed certain things, and therefore you also have certain duties to others, right? And so this brings us to this idea, this conception of the common good, which was stronger, I think, in the post-war period. And then by the mid-1970s, you see that sort of that idea kind of receding. And you see the rise of this other idea, which is the ethic of personal responsibility. We're all responsible for ourselves, our children, and we are supposed to be skeptical consumers in a market economy. We're supposed to read all of the data and the scientific information for ourselves. We're supposed to process research and make decisions for ourselves and ourselves alone as to what's good for us and what's not. We're only responsible to ourselves. There's a great sociologist, her name is Jennifer Reich, R-E-I-C-H, and a lot of her research focused on parenting culture and parenting culture around vaccinations as well. And what she talks about is she talks about the rise of individualist parenting, this idea that moms who are faced with the kind of choices that they're faced in a consumer-oriented society, 50 different types of organic baby food, have to themselves become skeptical consumers, experts on the decisions that they're going to make for their children. And if you extend that, now also maybe put it in a context of where you're coming from a community where you also have a huge level of mistrust of institutions because you don't feel like you're being supported. Vaccine hesitancy actually makes a lot of sense. It's a perfectly physiologic, rational response to the world that that these folks are inhabiting. But again, what research shows is while vaccine hesitancy is as old as vaccines itself, there have been ways where we've been able to address vaccine hesitancy and overcome it. And that wasn't done by simply, taking out more ads and telling people to get vaccinated. Certainly wasn't by hectoring people to believe in science and, do a better job of reading the research. But it's because there was the spirit of understanding that our individual flourishing was also bound up in collective well-being, right? And you need to live that, to see it, to feel it, to believe it. You need universal social programs that allow you to believe and feel like you're part of something greater than just yourself. So we need institutions to actually do things for communities, a robust welfare system that allows people to accept and say, when you say, why aren't you vaccinated? The answer is not, who are you to come here and ask me that? Do you know what they're doing to my building? Who are you to come and ask me that? Do you know what's happening on the street right now? And so I think I'm going to end it there. That's yeah, that's it. Thank you.
Thank you so much. When we were speaking earlier, I kept thinking, I know this name. And when you start talking, I realized I had my students read your article in my bioethics class, and it was just awesome. It was a big hit. It made a lot of sense to them. The thing I want to ask about is you concluded by talking about the need to reanimate the notion of the common good. And it seems to me that is a conspicuously absent notion, not only on the political right, but also on the political left. It's this sense that you're either responsible for yourself for making your own way, or you need help and we're going to help you.
Right.
But no sense that our well-being is tied up with the well-being of others. And I wonder if you could comment on that a little bit and talk about maybe what you think it would take to get past that. I mean, this pervasive individualism on both sides of the political spectrum.
Yeah. I'm going to start off saying I don't have any answers, so it's going to be disappointing. But you're absolutely right. It doesn't extend on either end of the spectrum. And I think, what we have to start by understanding is that I think that measures to introduce programs that were rooted in more holistic or social welfare have failed. You look at the history of trying to get universal health care in this country. I mean, it's such a sordid history, and it's been it's not from lack of attempts. It's from the partisanship, it's from lack of, political support, it's from the funding aspect, etc. And so I think when you've had setbacks like that, and instead you've had the rise of, other ways of then providing those services that are more akin to what we see today, it doesn't surprise me that either side lacks the vocabulary and lacks the sense of perspective to then put that into practice. It's not something that comes intuitively for us, but especially in an American, I think in an American context. With regards to how to get there, time and time again, I really look at this as they did it once, they've done it before, right? And it wasn't easy, and it was messy, and it was, I'm not saying it was perfect. It was difficult. All of the research from the time showed they had to overcome huge hurdles in order to have those programs. Medicare and Medicaid. You have to think about the fact that it's challenged every year. Every other year, I see a story about the fact that they want to cut it, they want to do away with it, they want to privatize it. And every time. So there's two things here I think that are needed. The first is that to actually pass those programs and have them come into effect. But once they're there, I think they're very well defended. Folks understand once they're in place, and folks that get to benefit from them and see the benefits of living in systems that provide that kind of support, that they're not going to let go of it, right? Of course, that's easier said.
Thank you.
So
This goes beyond vaccine hesitancy for me, and I'm really, we're talking a lot about community breakdown and connectedness breakdown, but I think that what's been most surprising to me has not been the vaccine turning against the healthcare profession, and from the we're the heroes early on into we don't trust medical or caring for our people, and the sense that it's I'm kind of the enemy, and there's a real difficulty in the normal connections where people come to the hospital, for example, to get taken care of for what happens in the care they get, to we don't trust you at the beginning with you about things. And for us, because we're in a rural community, as I work at Geisinger, we have always been a huge part of the community. The grandparents, the parents, the kids, the grandkids are all born at the hospital. And so we were always very connected with our community. And I even see that breaking down around ivermectin demands and around, having shorter visiting hours, and the sense that you're not being truthful. I don't trust you. So I'm trying to understand, beyond the vaccine hesitancy, there seems to be a breakdown in how healthcare is being seen across everything now. Are you seeing that, and what are people thinking and doing to work in that space?
Yeah, that's such a question. I want to say, I went to medical school and I did a lot of my medical school training in a very different system. It was in New Jersey at Rutgers Robert Wood. The patient population was very, very different. And then you get to the Bronx. And what you're describing, that sense of folks coming in on day one, kind of saying, I don't trust you, you're going to have to do a lot of work in this room to get me to believe what you're saying. And I think what's important to remember is, in spaces like parts of suburban New Jersey, folks very comfortable speaking and talking to medical professionals because they're coming from the same sort of class background. And the doctors are probably very much part of the same community. They're living in the same suburban neighborhoods. They're able to speak to a common language, commonality that's there. Whereas in spaces like the Bronx, nobody that I practice with lives in low-income housing. We don't live and shouldn't qualify for public housing. And so there's a different language barrier that almost has to be crossed, even if you're both speaking the same language, if that makes sense, because there's an acute sense on the part of the patient population that I don't understand, and I have not experienced the structural and social barriers that they face on a day-to-day basis. But there's also a real sense of, hey, you're a doctor, you're here to make money, you work for an institution that is essentially taking up real estate spaces in these neighborhoods, is not really giving back and just seems to keep expanding while NYCHA is like now facing possibly 50% of the stake being sold even more. And I think when we talk about not wanting to trust medical professionals, you have to also see that against a backdrop where medicine and hospitals have just gotten more and more successful and profitable. The hospital lobbying system in New York City is tremendous. I mean, it's incredible how much volume and how much money they make. And you don't see a lot of that being put back into the community, and communities are very acutely aware of it. I think what you're speaking to came way before the pandemic. And I think it depends on, depends on the community that you're from that's stepping forward to interact with these medical institutions. And I think one of the things that has to happen is that, one, there has to be more space at the table for folks in the community that you're practicing in to be a part of the ways in which these institutions interact with those communities and populations. And when I say, a seat at the table, I mean a real seat at the table, not the performative, like, oh, so nice you showed up today. Okay, thank you. That's it. A real sense of challenging and being able to say, no, you think this is important, but it's really not. This is what we're focused on right now. And I think what that also does is that it forces medical professionals and institutions to then also take a stance on the fight that these communities are having, right? Doctors simply can't be the people that just give you the vaccines and give you your medications. If you're practicing in the Bronx, I want to be part of the fight to save NYCHA. I want to be part of the fight that says, hey, you need more resources in this community. I want to be part of the fight that says, why is it that African-American women are not being given both the medical care that they need, but when they go home, they don't have the services and don't have the support that they need to be able to live the best life that they should be able to. But you don't see any of that. And so this idea that, one, from a community standpoint, there's a hierarchy and a difference between the people that are practicing and the folks that are there. Two, that it's siloed in such a way that medical professionals are not seen as having solidarity with the community. They're simply seen as providing a very specific, narrow service. And three, working for institutions that I think don't feel a sense of giving back to that community, or don't feel the same sense of obligation that, say, a public hospital system might feel, or a public institution might feel. Yeah, I hope it makes sense.
I have a couple questions from Zoom. So first one is a scary question. I'll begin middle of it. With the next pandemic we face, that's the scary part. What do you expect? Will our nation experience the same or similar resistance? Do you foresee vaccine hesitancy ever changing or lessening? What can the average person here do to help?
The next pandemic. Yeah. It's scary. It's scary if there is another pandemic. Unfortunately, at least from the perspective that I have from being in the Bronx, I think that in the next pandemic, there will be a shorter time span from when the pandemic hits to all of the measures that are put in place to address it. So meaning it took a while to get a vaccine, took us a while to normalize mask wearing, took us a while to et cetera. Whereas this time around with the second pandemic, I think it's just going to happen because a lot of that infrastructure is in place. What I don't think will change, unfortunately, is I don't know that we've done enough to reflect on, have our practices been effective for communities that we're trying to work in, and have we tied it to wider things or better things, i.e., we're still siloing a lot of our responses, right? It's kind of like there's a pandemic, oh my gosh, okay, red alert, let's go, let's get this done. Rather than thinking and saying, hey, the first time around we did this, the community that had the most number of deaths also didn't show up to get their vaccines. Why was that? And how can we change some of those responses that we had to make that possible? And so unfortunately, I think, and I know I sound very pessimistic saying this, but unfortunately, I think without that reflection taking place now, the next pandemic, you'll see a shorter time span to mandates being put into effect almost immediately, but you're still going to see the same level of resistance. And that's because nothing underlying those measures has really changed. That landscape hasn't really been addressed. I'm sorry, I forgot the second part. Oh, how can the person help? I think that ordinary people do exactly what they're doing. They do the best that they can. It's astonishing to me, despite the challenges that you see in the Bronx, it's really tenant associations and grandmothers getting together, feed the community, to get a hold of hand sanitizers, to bring masks into these buildings, to help babysit other people's children because mom is too sick or dad is ill and you don't want the kids to get sick. Forging those relationships and then saying, how do we keep this going even after the pandemic is over, I think is one of the key things that I see as being both an answer to, but also a way out of the pandemic and being a stronger community. But the second part is also, taking on the fights that you see your neighbors having. So this idea that I'm not going to be affected because you're losing your housing, I don't think that's true. I think that when you see something like that and that measure is taking place, being part of that struggle, I think makes it possible to forge the community even stronger. Also allows in that next pandemic to say, we learned from those measures. This time around, we're gonna be even stronger.
Hi, thank you very much for your talk. I'm a little bit skeptical about the breakdown in community narrative that's behind some of the analysis. Just because one of the things that I saw during the pandemic was the creation of alternative communities, actually. So when you have a community like the Bronx, which from all the things that you've been telling us about has been disenfranchised from political decision-making and so on for so long, it seems to me that there might be a sense in which saying no, now that we're needed, is a way of reasserting our agency and demanding a place at that table you were talking about. And likewise, I also see the formation of new political communities online, where I can gain a lot of status by not just saying no to the vaccine, but posting it afterwards and getting a little bit of schadenfreude from the pushback that I get online. So I'm really curious to hear whether any of those kinds of sentiments were expressed in some of the interviews that you did.
Yeah. It's interesting. I did not hear I expected to hear a lot more of it, but I didn't hear as much about I'm not getting the vaccine and it's a form of resistance. Even if you could conceive of it that way. It was seen more so as something that folks were very suspicious of. And so it wasn't seen as resistance so much as self-protection against the vaccine. And against big pharma or institutions that were pushing it. For the online aspect, I don't see too much of it in the Bronx, so I can't speak to it. I don't know. I will say that I think one of the things I do hear a lot about is that folks are on lots of WhatsApp groups, and the WhatsApp groups end up being the way that information just spreads, and the way that information spreads is people not only spread it, but for some reason it's more memorable, than anything else you say. So it's like, I'll spend an hour and then the following week they'll come back and they'll still talk about the WhatsApp group message rather than what I said. And I'm like, come on, like, what is this? But I think that speaks to, these are voices and these are WhatsApp groups that had started that conversation way before the pandemic. So they already have a space in that person's mental space, right? And they're already listening to it. Whereas they haven't really, had the closeness or may not have had that relationship with healthcare providers. And it really took the pandemic for that to bring that about. And so, there's this question of where, again, I think having community level involvement at the level of these institutions, in addition to these broad social programs, being a way of saying, how do you take up mental space? How do you make sure that when I do have something important to say, I'm listened to already, rather than, oh, you're going to go online and look at your Facebook group, or you're going to go online and look at that WhatsApp group instead. And I'm going to have to start, at that point, when you're competing for that space, it's like you've already lost, right? Or you're already behind. That's my sensibility of it.
One more from Zoom. So excellent presentation, really thought-provoking. And then this is a comment, and the person would like you to comment in turn. So medicine reflects the society in which it occurs. The U.S. economies of employment and marketing are rapaciously exploitative. Healthcare can't overcome this model, especially with the devaluation of personal physician-patient communication.
That's a lot. So, yes, I think that absolutely exploitation is very much built into the model. So this reminds me of something, bringing it back to the Bronx. So there's a group called the Young Lords, which is kind of the Puerto Rican equivalent of the Black Panther Party. And the Young Lords were young revolutionaries organizing in the Bronx, took over church spaces, started community organizing. They were radicals. And one of the things they also did was that they took over Lincoln Hospital. They walked in, marched the administrators out. And Lincoln Hospital at the time, this is a New York City health and hospital system, at the time when they did this was known as the butcher shop. People would get admitted, you didn't know that they were going to come back out. Folks talk about sitting in the ED, waiting to see a provider, and they would look down and there would be like a pool of blood that hadn't been cleaned up since the day before. And so really sort of wretched conditions. But something that I think the Young Lords did that I think was pretty impressive was that they said exploitation can't only be one-sided. You can't talk about it only in the context of the patients. You have to talk about it in context of the workers that work at the hospital, because they're not happy either. And this idea of saying there's a solidarity here that we're seeing, right? Which is that we're all working people, and there has to be a way where we can forge those bonds on that basis, rather than creating the animosity that exists between us. Takeover of Lincoln Hospital was only for a couple of hours. Unfortunately, they actually ended up calling the National Guard and arresting the members and marching them out. But it's to me, it's one of these sort of examples of where the patient physician model, in part, I don't know if the person is saying that it's exploitive, but there's a vertical power dynamic that's there, and you have to even that out. You have to think about, instead of thinking about that relationship from a charity model, you have to think of it from a solidarity model. What is it that we have to learn from patients as well? And then how do you make the connection with the communities that you're in based on the commonalities that you have? So how do we talk about what it means to work in America, in a very exploitive country, in the context of a pandemic? What does that mean to show up to go to work every day? And kind of use that maybe as a starting point to move forward, at least until we win, universal healthcare, right?
So I have a master's in public health too, and I kind of shuddered when I saw this country's original responses to the pandemic. And by the way, also you went to my alma mater, Rutgers Medical, Robert Wood Johnson. Yay. Go are you. So I wonder what your thoughts are on the effects on public health law as a means by which to help get through these types of events. To me, it seems when you look back through the history as far back as Jacobs v. Massachusetts for smallpox
yeah.
vaccine, you then move forward to mandates you talked about for school-age children, for polio, all this. And yet at first blush, the federal mandate for federal government employees to be vaccinated got shot down because it was unconstitutional. So what, if anything, then is the role of utilization of public health law going forward for some of these types of things? Because you saw in individual states were effective, perhaps, but then state to state, there was so much variability that, somebody could just point, hey, they're not doing it. Why do I have to do it? That sort of thing. So what do you see as public health law going forward and its role in these types of events?
I'm going to be honest, I think that's a little above my pay grade. I'm just a PGY. My sense is that, I've mostly read about the public health law around the MMR vaccine. And to me, it seemed that the law kind of followed what was already public opinion and what was already accepted, which is very different from what we have, which is, we're having to have mandates in place. And even then, it doesn't seem to work because nurses walk off the job and, entire tech departments evaporate overnight. And so on one hand, there's a sense of there's laws that that come to place and go into effect because this is public opinion already and it's part of the landscape, versus we very much, I think, currently use it and moving forward are going to use it to institute, a way of saying you have to do this, no debate. There's no conversation here. The question I have is, when you start using it as a means to, to impose something, right? You now what kind of system or the justice system does that entail? What does that look like? And is that fair? Does that match the, will the penalty match what you assume look the level of the crime? And how do you make that distinction? I don't know. I don't know how you formulate that. But also, given that the justice system doesn't work equally for everybody, it kind of worries me in the Bronx. What's going to happen to some of my if they decide to not get vaccinated and it's law? What does that punishment look like? Will it inevitably, instead of leveling the playing field, increasing overall numbers, will it actually widen the social disparity that we're seeing? Meaning even less people in the Bronx will have access to services and, their social determinants of health will continue to look dismal versus folks who don't need those laws to begin with, right? Doesn't touch them. They're going to get vaccinated. Yeah, I don't know the full answers to that, but that's kind of my feeling.
Thank you very much for your presentation. I especially appreciated the picture from my childhood.
Oh.
Sorry, the 1960s photo. I had a lot of ideas going through my mind as you were speaking. This notion of the many years of structural injustices that exacerbated the problem in the Bronx, like food insecurity, intergenerational housing, and so forth. And the distrust of the healthcare system. So I'm curious about your thoughts on some possible responses. If the community distrusts the healthcare system and healthcare workers, this may be naive, but why not bring more healthcare workers from the community? And some sort of investment in what would require education and training to develop more healthcare workers from the community. So that's one thought. And I'm sure you're familiar with programs like food pharmacies where physicians or nurse practitioners are prescribing a
scripts.
healthy diet, right?
Yeah.
Likewise with housing, it seems to me that since that's such a critical issue there. So I'm just curious as to what you think about those responses.
So I will say that almost all of the nurses that I've met that I work with at the Montefiore Medical Center are from the Bronx or live in the Bronx. You know, they're from the community already. The 1,400 that were fired from the neighboring healthcare system, they're from the community. And it wasn't surprising if you understood that to then see, well, the community's not getting vaccinated. This is, you know, they're part of that fabric that's happening. And so, you know, I also think as, you know, as a resident, even if you come from the community, what's actually shaping the way you operate is the institution. You know, once you come into the hospital and you're working there, things that you have to do and you have to fill as part of the job, unfortunately doesn't, at least for us at Montefiore, there's not a lot of space there to be able to infuse it with saying, well, I'm from the community. And so, you know, in the community, this is how we do things. And so there should be a slightly different response. It becomes, when I come to work, I'm a nurse. Here's what has to get done. This is how I'm going to do it. So I think it has to really be an institutional level change rather than just at the worker level. Because the institution has that power to change things at that level. With regard to food prescriptions, you know, part of the issue is that we just don't, you know, in a space like the Bronx where it's so crowded already and real estate is such a hot commodity, we just don't have the space, and there are no, you know, folks live in food deserts, part because of course groceries are expensive and they don't want to open there, but also that like there's no space to put it. Where are you going to put it, you know? And so it's also about saying, you know, how do you prioritize and say, I'm going to give incentives for folks to open up grocery stores here, or I'm going to provide incentives for certain businesses to succeed, maybe at the expense of others. I hate to say it that way, but it's true. So that instead of, you know, 3 fried chicken pizza places, you're seeing at least 2 of those turn into spaces that are catering to something else. But, you know, the last thing I want to say is that, you know, from my, you know, a lot of my patients, you know, it's not that they don't know that they need to be healthy, and it's not that they don't know that they should go buy fresh fruits and vegetables. But if they're working 2 jobs, and by the time they come home to put food on the table, they're not thinking about vegetables. They've had a long day, they've been on their feet, they've had to put up with, you know, so much at work. They come home to these neighborhoods, there's more fighting, more fights they have to do to keep going. And at the end of the day, they just want a pizza, you know, they want those things. And it's hard to be able to say, how do you address what it means and the stressors of what it means to go through day to day, every day, and have that translate to, yes, I want to eat a salad with, you know, bell peppers and tomatoes versus, yeah, I kind of get it. Of course you want to eat that slice of pizza. I don't know what the answer is to that. You know, it's a tough thing. I do know, you know, when I used to work in India, one of the things I appreciated was that every workplace has its own kitchen and cafeteria, and folks eat on the premises. And those kitchens and cafeterias, therefore, had a lot of influence on what we ate. And in the days they decided to be super healthy, people would grumble, but they would eat it. You know, you're going to eat what you're given. I don't know, you know, I don't know if that's part of the answer. I don't know what that looks like, but I like the idea of the food prescriptions, as long as it's tied to something on the other end where obviously it's subsidized or they're going to be able to have access to those things. Yeah.
Thank you.
Thank you so much.
So we have a break till 2:45, and there are refreshments outside, right? in the lobby. Okay. And Zoom people will just turn off the camera and mute for a little while, but we'll be back 2:45 for the last session. Thank you.
Thank you so much. So nice to meet someone else. Sir Robert Wood Johnson, it's amazing. That's so great.